This week on the BackTable podcast.
And as we all know, there's not a complete consensus on everything. There are things that we know, there are things that we don't know. There are different ways to approach these lesions, multimodality, not just Y90. There's a lot of options for these patients, right? So we
what makes me
the
most excited is we were not having this conversation 3 years ago.
Yep.
Exactly.
Right? So I can only imagine what 3 years, like they're going to look back at us saying, you know, some of the stuff we said today.
So archaic.
What do you mean they're going to look at us?
Yeah.
We're going to look at us.
No, this would be somebody else. So archaic.
Yeah. Well, I'm going to solve the abscopal effects. I'll be on my yacht.
Oh, there you go.
Yeah.
There you go. There you go.
This is Dosimetry University, Part 6.
Okay, so let's get to some Mets. What Mets are you both treating? I know we talked about this a little bit earlier, but what types of Mets?
We treat anything that gets referred to us. We have a big, and what insurance will approve.
Also, true.
I think also something to consider. We treat a fair amount of lung Mets to the liver. We'll treat obviously tons of colorectal Mets to the liver. Metastatic cholangio, which, you know, multifocal cholangio. So which we'll treat breast, we'll treat gastric, and we've treated RCC and melanoma. I mean, those are the ones that
The full
come to mind. Yeah, we don't necessarily balk at anything. Obviously, again, all depends on what the mapping shows you and what kind of dose you can comfortably deliver.
Of course.
There was a really cool paper. To your point, we treat everything too, and we'll talk about clinical scenarios where it probably makes sense to treat some of these unconventional tumors. But what I really liked is to see that that's nationwide, right? So the Resin Registry, which is a registry of many centers within the U.S., looked at all patients who were treated with radioembolization, particularly with resin microspheres. And there was a nice paper published in JVIR last year that compared CRC, so colorectal cancer as the baseline, and they looked at how patients did compared to a reference of colorectal. And it was really fascinating to see. Some tumors did really great, right? Like ovarian was on the list. And I didn't even think about ovarian tumors being, you know, something we could treat. And I've treated a few since then too, for that reason. So I really encourage everyone to go look at that because it was really fascinating. There was like 20 different tumor types on there. I think lung and pancreas tended to do worse than colorectal, but that also might just be because it's lung and pancreas.
And did it say if it was low bar treatment versus rad-seg, or didn't really specify?
No,
Yeah,
just
all covered. Okay.
that particular paper just looked at the Resin Registry.
So also doing a little bit of everything, right? What are your thoughts on liver dominant versus liver only? I mean, I assume you'd both treat liver only. Will you treat liver dominant?
Yeah. And so the question is, what's going to kill the patient?
Yep.
Almost always it's liver failure. Whether it occupies enough of the sinusoids that they run into synthetic liver dysfunction, and end up dying of that, or if it pinches off like a bile duct, and then they end up dying of hyperbilirubinemia and not being able to get, you know, systemic therapy for that. In general, I like there to be, you know, some sort of plausible clinical benefit for the patient. So if they have widespread metastatic disease, but they're relatively stable on chemotherapy and their main issues are having like right upper quadrant pain from the liver tumors, I would offer radioembolization for even if they had widespread metastatic disease.
Yep.
And there's really good evidence to that effect. There was a randomized controlled trial looking at whole liver radiation, 8 gray single fraction SBR, or not SBRT, but external beam radiation therapy. And they actually showed in a randomized phase 3 trial that the pain scores are significantly better than people just on best supportive care.
Yep.
So even if they have widespread disease, if they're in pain because of their liver tumors, it makes sense to treat.
Yep.
No, I think that's a great outreach opportunity, right? If, let's say I'm working in private practice and I don't necessarily want to turn away cases that get referred to me, right? I want to try to find solutions for patients. But if I can find solutions for physicians that might increase my referral base, right? Like if you have patients that are having, it's a nice it's a nice collaboration builder for an interventional oncologist or interventional radiologist to help increase the referral pattern from oncology, because it is a benefit for patients, right? And I think oncologists don't appreciate the fact that we can sometimes have palliative approaches that will benefit their patients as well.
Yeah, great point. But going back to this liver dominant question, let's say they're not on systemic therapy and they're not palliative going to, you know, hospice, kind of going that direction, right? So liver dominant disease, extrahepatic disease, not getting systemic chemotherapy. Do you still think there's a benefit?
I think there is, but I think you got to understand within the context, if you have extrahepatic metastatic disease that's uncontrolled, it's going to progress, right? And so I don't think it's unreasonable to do.
Especially with dominant, bulky liver disease, right? So I
don't think it's unreasonable to do that, but I think you got to understand that you're gonna get a follow-up scan, and let's say they have lung mets or an adrenal met, they're gonna look uglier on the follow-up scan because they were left untreated.
Yeah, I think that's one of the challenges. We don't have a lot of data to support that treatment paradigm I think we all probably do it. I assume you do as well, right? Because we are trying to advocate for the patient and trying to help the patient to the best of our ability.
The question is, why are they not getting systemic therapy?
Yeah.
If it's they just don't want systemic therapy because they just don't want it, but they're fully functional and everything like that, then you have to have a tough conversation. And maybe it's you with the oncologist with them saying, I can do this procedure, but you're going to recur, you're going to have worsening
of course.
progression.
It's setting expectations.
And then you're going to have, again, going back, all the toxicity with potentially not a lot of the benefit, right? If it's they've tapped out of chemotherapy and they're just burnt and they're like, you cannot put that stuff in me anymore. And you see they have mostly liver disease and the liver disease is what's going to kill them.
Yeah.
I think you're still kind of out on one leg, but you have more of an argument to make there than not. And, it's also the degree of extrahepatic disease. If they have 2 tiny little lung nodules, but like 7 bulky liver tumors, that makes sense to treat even with the extrahepatic disease.
Yeah. Yep. Great points. What about sub-ablative dosing with immunotherapy, right? And this actually includes HCC a little bit. This is not just focused on Mets, but when we're talking about immunotherapy and we're giving ablative dosimetry, is that what we should be doing? Should we be giving sub-ablative dosing for some of those tumors? That's a tough question. It's just meant to be.
So you have to redefine that, right? Because we have really good evidence, particularly from the CART registry from Europe, which showed for colorectal, HCC, and cholangio were the 3 big ones they looked at. Non-ablative, but partition dosimetry that wasn't rad-seg actually had decent survival benefits, right? And you can go and look at those papers and it was great, right? So I think that's different than trying to go for an abscopal effect, which I think is what you're alluding to, which is we're going to give subtherapeutic radiation doses and anticipate stimulating an immune response in order to generate off-site, off-target antibodies that are going to attack the tumor. I'm sitting here giving you a BackTable podcast episode. If I had to figure it out abscopal, I'd be on my yacht somewhere else.
Exactly, right? Like it's not something that we have yet to figure out how to reproduce with 100% confidence. Yeah. Is it a consideration? Certainly. But at the end of the day, I would rather prefer to be ablative as opposed to sub-ablative.
When you can.
Yes.
Yeah, absolutely.
Outside of a clinical trial, I think it's really risky to be trying to promise patients or suggest to patients that you can get an abscopal effect.
Agreed.
Because I don't think we can reliably do it. We haven't proven to be able to reliably do that.
With any technology.
With any technology. And I think the patients should be on a clinical trial because all of that is explained up front and they're being very carefully followed afterwards.
Agreed.
To demonstrate that.
Well, I think talking about abscopal effect, to your point, in clinic and having that idea in a patient's head is probably just wrong.
It can be dangerous, right? Because not only are we stimulating immunologic effects to generate antibodies, anytime we do anything to a tumor, we're also kind of kicking the hornet's nest and doing pro-tumor and anti-immunologic effects as well. And so the hope is one day we can find a way to balance it such that the pro-immunologic effects outweigh the anti-immunologic effects and the pro-tumor effects. We just haven't been able to do that yet. And so I would say outside of a clinical trial, I'd be very cautious about that.
Yeah, agreed. It's a great point. Threshold dosing for Mets. Curative intent or ablative intent versus palliative intent. Are there targets that you are trying to hit to the tumor?
So when it comes to radiation segmentectomy,
for Mets,
right? So I approach metastatic disease 2 different ways. I try to do radiation segmentectomy when possible.
Sure.
So if there are a few Mets, bulky Mets, I will try to isolate and deliver an ablative dose to those, whether it be several feeding vessels or to multiple tumors. I would try to do that. My target is, again, still right around that 400, 500.
Well, that's all we have,
perfuse, right? That's based on the HCC stuff.
Agreed. Yeah.
If it's diffuse multifocal disease, I tried, and patients have been on multiple lines of chemotherapy, or even if they haven't, you have to consider what your dose to normal tissue is, right? Because that's going to be the big impact play down the road. So I like to look at what my dose to the normal tissue is in a more high perfused volume setting. So if I'm treating a lobe or an anterior posterior division, I'm focusing more on 70 gray to the normal tissue, and that's where you have to kind of actually draw out you can assume just everything is normal. If you don't have software to use it, you could say all of this perfused territory is going to be whatever I want my normal liver dose to be, and with glass it's going to be 70, with resin it's going to be 40. Or I can use the software to actually draw out what my tumors are relative to the perfused volume and my normal tissue is, and calculate a T-to-N ratio. But that gets into partition dosimetry, which I would love to have hear your thoughts about, Zach.
Yeah. So again, alluding back to the CERT registry, where they looked at HCC, colorectal, and cholangiocarcinoma, they showed that partition dosimetry, they didn't even consider what the doses were, but just the concept of using partition dosimetry had a survival benefit over other empiric methods like BSA.
Yeah.
For treating
and multiple tumor types, not just single tumor type.
Correct.
So, yeah.
And so the exact numbers for what to use for each product, I think, are still being figured out to this day. But in general, like you said, for glass microspheres, 200 dose, 200 graded to the tumor, 70, 75 grade to the background liver. Resin microspheres, 100, 120 to the tumor with 40 to the background liver. There has to be a huge asterisk next to all of this, because as resin becomes more and more and more pre-calibrated, this is all a function of specific activity. There's nothing intrinsic about the resin. It's, more toxic to the liver than the glass, right? It's the radiation that's causing this. So as we get higher and higher specific activities with more pre-calibrated resin, we're going to find ourselves coming to a convergence on dose to the tumor. So if you have a 7-day pre-calibrated resin microsphere, you're going to have to come closer to the 200 grade of the tumor,
Sure,
rather than the 100 grade of the tumor, as if you had day of calibration microspheres.
Now partition is synonymous with multi-compartment dosimetry. To do partition dosimetry, you have to have software, right? Because you have to have something that can, or you have to be able to measure the uptake in tumor relative to the uptake in normal within that perfused territory.
If by software, all you really need is a spec CT with a way of measuring the counts, right? The simplest way of doing this would be draw your tumors of your regions of interest on your spec CT of the tumors, do it of a few areas of the background liver. That gives you a rough T to N ratio, and then use that to then plug into a cancer Y90 app, right?
Yes.
And I think most people have a spec CT that can calculate, or a SPECT that can calculate relative counts.
But I think people that say they do partition dosimetry, or say, I know what T to N ratios are, my T to N ratio is 3 to 1. Well, you better have something that's telling you that, whether it be spec CT or spec CT built into a software, or looked at via Simplicity or MIM. Or
so that's like the next, that's like 301, right?
Yeah.
And we'll get to that. But if we take the simplest person out there who only has a spec CT,
yes,
I want them to feel empowered. They can do this, right?
Sure.
All you have to do is look at the relative uptake in the tumor and the relative uptake in the background liver. It'll give you a rough number. And then you can plug in these apps and you can actually see the difference, right? There's super hypervascular tumors, neuroendocrine tumor, for instance, where you plug it in there and you compare it to 100, let's say you're using glass. You may only need to give a MERD dose of 60, because these things are so hypervascular, right? In order to get a tumor dose of 200, right? Commonly what I see in resin is that the BSA dosimetry is too low, and it's predicting that I would need less activity than I actually need. And the partition says, oh, maybe you need to bump it up. You're going to be safe bumping it up.
I guess what I'm trying to say is you have to be looking at counts, right? You can't just guess based on the way your DSA looks that this is, the preferential flow. You can't make assumptions on your T to N ratio just because of the way the tumor enhances.
And historically, people just took a TNR 4 for HCC and calculated it, right?
It's not fair to just guess or make up.
No, I agree completely with that. The best surrogate we have today is MAA. Mm-hmm. I would love for other better surrogates to be made, but the best we have for today is MAA, and all of the trials, Dosisphere, et cetera, was based off of the MAA. Yeah. So the best we have is the MAA, at least for today.
Yeah, and we talked a little bit about this earlier, Zach and you weren't here, and I know we've had these conversations on the side as well. I think that's something that I just personally struggle with, and I routinely do my TNR post Y90 delivery. And the disparity, which one is right? Number one, obviously, we assume that the Y90 scan is more appropriate and right. Then that gets into the lack of resolution on SPECT-CT and PET-CT as well. And so there are a lot of confounding factors in this process that make it a little bit more challenging.
What makes me the most excited, though, is that people are talking about this now.
Yes.
Right? And so 2025, we may not have all the answers. By 2035, I think we're going to be a lot closer to the truth.
Yeah.
Right? And so, when I was in my training, it was 120 grade MERD glass, BSA resin.
Yep.
And that's just what everybody got.
Yep.
Right?
With sterile water.
Yeah, exactly.
Yeah.
Today, we're actually talking about, dose to tumor and dose to background liver. My fellows today are way more sophisticated than I was when I came out.
Oh, I didn't know anything when I came out of fellowship. But let's go back to that case example. Bilobar disease, TNR of 1, if that, 70 grade of the background liver, will you still offer it?
I think if that's the if there are
best you can do.
If that's the best you can do, I think that's the best you can do. I think sometimes, some of these tumors are more radiosensitive than others.
That's also part of it, right?
So I think it's a good offering. I think you have to make sure that you don't hurt the patient in the process, and that's why I think treating the background makes the most sense. Treating to what the liver would tolerate for you. That, I think, it's not my first approach. It's not my second approach, but it's down the line of the offerings that I would provide. I don't know. What do you think, Zach?
I think we're starting to understand a lot more about the pressure augmented deliveries of these things. Again, with the balloons and the microvalves for particularly lobar deliveries.
Yes.
They can really augment the tumor to normal ratio. I think we're at the very early phases of understanding that. I don't think you're going to turn that hypovascular tumor into a rip-roaring hypervascular tumor. But let's say it was mildly hypervascular, but you just, maybe the T-N ratio was like 1.5 or 2, right?
I would consider, I do think flow altering,
Flow augmentation
is a good approach there. And that would be earlier in the line before I just did a standard end hole catheter lobar delivery.
Sure.
I would have pulled out a TriNav and I would have seen, hey, is there flow alteration to the tumor now with it, within the vessel?
And again, it's not going to turn this hypovascular tumor into a hypervascular tumor, but it can push you over the hurdle. I think this patient, no matter what you do, would be a struggle. Yeah. But again, I think the borderline patient, 1.5, 2, if you can get them up to a 3 or 2.5, 3, now you're starting to look at a much more favorable, particularly if the tumors are quite large and you're playing around with the dosimetry, you can get much closer to favorable background liver doses.
Great point. Particle count in these kind of situations. High particle count, low particle count. I'll tell you what I do. Why don't I start with that while you think about it? How about that?
Well, I mean, I can tell you what I do. I love the par thing, but you go first. And let Zach talk before me so I can piggyback off what he says.
So I will say, there's definitely data that shows that increasing particle count will lower TNR in hypervascular lesions, right? So anybody where I have hypervascular disease and I have a large amount of normal liver, I tend to minimize my particle count a little bit. I'm not saying that I'm right in doing that. That's what I tend to do. But then the question is, for the opposite, for these hypovascular lesions or relatively hypovascular lesions, is there utility in actually increasing particle count? Then again, the background dose threshold changes. We've said that about 14 times today. But is there utility in increasing the particle count in those situations? And maybe we don't have the answer, but I'm asking, what do you guys do?
So I'll stick with what we know first. And then we can explore, fantasy land in a second. What do we know, right? So we have a phase 3 trial looking at this thing, which was the EPOC trial, right? And they broke EPOC. Unfortunately, I'd love to use Surfox, Foxfire Global. They only had day of calibration, right? So we're stuck with EPOC. EPOC looks at their outcomes in people who were treated in week 1 versus those in week 2. We didn't see any difference, right? So theoretically, your particle count threshold probably doesn't make a difference in that perspective.
Yeah.
So I
don't know hypervascularity of those tumors.
Exactly, right? So, there's so many caveats, but that's where we're at today.
Yes. Yep.
Right?
Good point.
And so I can see the argument both ways. The first way of the argument is when you do your MAA, that's roughly 4 million-ish microspheres, quote unquote, rough worth. So some people would say you probably want to mimic as close to the 4 million microspheres possible. I don't know if that's actually true or not. And I definitely do feel better if there's like a 14 centimeter tumor if I put in more microspheres.
Sure.
I don't know if that's actually truth though. And I think that's one of the biggest open questions we have right now is the microsphere conundrum.
So forget large tumors. What about just bilobar disease? Same answer? Bilobar multifocal disease. Okay. I'm not saying there's a right answer, right? We don't know. So
I tend to like fewer particles because even if it's heterogeneous distribution in normal, it's a more heterogeneous distribution in normal. So for hypervascular lesions, I prefer a lower particle count. For hypo, again, you have to figure out where your preferential flow is, right? If there's no uptake in the tumor, you might stand to say, hey, I'm not going to do anything good for this patient. But if I just trash their normal liver without doing a favorable dose, and that's where that concept of, super selective, like pushing dose into hypovascular tumors, altering it with a flow augmenting device, whether it be Sniper or TriNav. I don't like to think of this high particle count, high particle load, because I find that the high particle load, I'm talking like, super, super cold doses. I just find that you wind up destroying a lot of normal in the process of trying to get dose into tumor.
Which is why the threshold doses are different, right?
Yes.
So 2 different animals, 2 different products, right? And I think we're trying to better understand where the exact utilities are, right? To your point, Zach. So we're redosing. in a low bar fashion. If you've already dosed to threshold, will you redose?
This is what I love about, and this is probably the most common question I get, which is, what do you target? Do you target a background liver dose and max that out, knowing that your tumor dose might be like 400 gray or 200 gray if you're using resin? Or do you target an effective tumor dose, even if the background liver dose is like half of the upper limit, 20 gray resin, 40-ish gray glass, 35 gray? And I actually target to the tumor dose that I know is effective. So like 130 gray with resin, 200-ish gray with glass. Knowing that
for Mets.
Yeah. We're in Met City right? Because I know these patients are going to recur. I need to be able to have something in my back pocket.
Okay.
Right? And so if I gave 20 gray background liver dose, and I know in my experience, most of the times they recur with new tumors, not the same tumor. And so if I have background liver dose to go back in, my colorectal patients, you're 8, 9, 10 months later, you might have to redose them again. And knowing that you were well below the threshold limit gives you a lot of comfort that you're safe.
I think it's a great approach. I don't know that we normally get patients that have already gotten there. If they have bi-lobar disease, we tend to get them after they've exhausted multiple lines of chemotherapy, and this is kind of like their Hail Mary. So I don't know that we necessarily get those patients coming back to us too often to do additional treatments down the road. Yeah. But I like the approach of targeting effective tumor dose. I think that's the right approach for those patients.
It's a lot of conundrums as we've talked about. But then the flip side of this is also true, right? You can definitively give too little particles as well, and just not have the distribution that you need. So what about things like mutation status? You guys pay attention to mutation status for colorectal mets? Ki-67 for neuroendocrine mets?
You go first. I talk too much.
That's fine. The first answer is easy. No. As far as like KRAS or BRAF, you read one study that we published and it says like the left-sided tumors do better than the right-sided tumors. You go read another trial and they're like the right ones do better than the lefts. And I'm like, well, what about the ones in the middle? And so I really struggle with that kind of stuff.
And KRAS is a very common mutation as well. Right?
Yeah,
and it's
exactly.
Yeah.
And so I think it's incredibly important if you're a medical oncologist and you have targeted therapies.
Yes.
But for us, the radiation is relatively agnostic. Now, there might be some mutations that might have poor outcomes, and you might expect to counsel your patients about what to expect after the procedure. If they have particularly, bad.
That's where I use it exactly. Yeah.
But I wouldn't change my dosing.
Agreed.
Based on mutational status, or whether or not I was going to offer procedures to someone based on mutational status. Ki-67 in the grade of neuroendocrine tumors, we should table for a different discussion because that's a much different topic than just mutational statuses.
But it does affect how I approach Y90. Ki-67 does matter in the neuroendocrine game.
Correct. Let's do that next.
Yeah. Okay. Sounds good. Lines of chemotherapy. Do you care? Do you worry about it?
I think you should. I think that
I agree.
After they've had multiple, I think their liver is much more, even though they might have a normal liver function, even though they might, if they've been on 4 lines of chemotherapy and they look good, that liver's going to tolerate radiation a lot differently than somebody that has only seen 1 line of chemotherapy. So again, I think you're still stuck dosing to normal, but understanding that sometimes maybe they've been on a platinum-based agent that's more radiosensitizing. So they might take a hit a little bit differently than somebody that maybe didn't get exposed to it. So it doesn't stop me. I do pay attention to it. I am not as aggressive as I might be for somebody who I'm catching earlier in their chemotherapy algorithm.
Let's talk about the other end of the spectrum now, which is first-line therapy, right? You have someone first-line colorectal cancer. Do you offer radioembolization? And so we have 3 negative trials in that setting to show that the addition of Y90 with full Fox or full Fury plus or minus Bev.
Which were the 3? Just
Fox, Foxfire, and Foxfire Global. That were all negative. And many people would argue they're negative because they were using BSA dosimetry and they weren't using partition dosimetry, but that's where we're at today.
Yeah, right.
So for the most part, first line therapy, colorectal, I also don't necessarily offer it, with a huge caveat. The caveat being, as you mentioned, we have the CLOCK trial and we have Collision, which are ablation trials, showing that if they have quote unquote ablatable disease, they probably do derive a benefit by having that ablatable disease treated. So let's say I have a high segment 8 lesion that I can't ablate. Maybe if I was in Europe, I'd feel more comfortable doing because they're a lot better at ablation than I am.
Do you have a robot?
But I have a robot. I might consider doing an ablative radioembolization in that context, first line therapy. But if it's just diffuse bilobar, probably not going to offer radioembolization up front.
I think you see somebody for the first time with metastatic colorectal disease in the liver, you got to figure out how that tumor is, or that tumor biology is behaving too. So sometimes our standard practice at Ochsner is they're going to get chemo, and we're going to see how they do on chemo. Because they might have micrometastatic disease elsewhere, and it just has not demonstrated itself. So I don't know that jumping the gun early on makes a lot of sense. So sometimes we'll give chemo, we'll do an early restaging scan, and if that's isolated disease, then it becomes a discussion of resection, ablation, or ablative Y90.
And clock was with first-line therapy in particular, right? So yeah.
I like being aggressive out the gun, but I think sometimes we can be too aggressive and not appreciate the fact that we just haven't seen the micrometastatic disease and declare itself.
And I have yet to see a good outcome for a colorectal cancer that does not respond to FOLFOX.
Exactly.
FOLFOX like melts these tumors.
If they're going to.
Yeah.
Yeah.
Mm-hmm. And so you adding Y90 to that patient may not help their course.
You missed my case this morning, third-line therapy, so it's okay.
Okay. Sorry, I had to treat patients.
No, I know.
Well, you could have rescheduled them, but we'll forgive you.
I think this goes back to the discussion on mutational status as well, and how I use it, looking at microsatellite instability and KRAS and helping to guide the patient and set expectations.
So do you use it? Do you use mutational? Like, does it
Not to change my-
how you would does it change anything for you?
It doesn't change my treatment plan necessarily. It changes how I discuss outcomes with the patient effectively.
Okay.
Right? So that's where I use it. I agree. We still don't have a tremendous amount of data. I think as we go forward over the next 5 years, we'll place more of an onus on mutational status and hopefully derive which treatment pathway is better for which mutational type. That's what I hope. We're not there yet, but yeah. Imaging follow-up of these patients. Should we be using mRECIST and not RECIST 1.1 for the hypervascular lesions?
I think mRECIST is better. I think for hypervascular lesions.
Yes. But the standard in the community is to use RECIST 1.1, right? And all the papers use RECIST 1.1.
Exactly. I don't know that I necessarily, at the end of the day, I don't think you're going to break what everyone's tradition is. I think it's hard to break tradition from that when it's helping guide the way that I'm going to approach a patient. And I think sometimes we have to stand in and say, hey, you review the follow-up scan with your oncologist. Sometimes it's in a multidisciplinary clinic or a tumor board, or maybe it's just a side conversation. When you're doing a follow-up with the patient or the oncologist is getting their expected follow-up, you can say, hey, look, these tumors look treated to me. I know they're going to read as stable disease on imaging based on RECIST 1.1, but from an mRECIST standpoint, these are responded tumors. I think we don't offer any more local regional therapy at this point, or maybe some of them responded, some of them didn't. Let's go clean up the rest. Yeah. But you have to have a side conversation with your oncologist on those cases.
But that's part of being a clinical interventional oncologist,
correct,
and not being a proceduralist, right? I think we're past that point. Being more actively involved in the treatment planning long term for these patients longitudinally is very important, right? So, Zach, how do you treat miliary disease?
That is a struggle.
Yeah,
that's something we really, really, really struggle with. And the solution I've come up with, and I'm actually really excited because you said it earlier, and the fact that you live on the other part of the country and functionally a different world than I live in and came to the same conclusion I did, tells me there's probably a bit of truth to it, which is I dose to normal. I assume I'm only treating normal liver, and I give a healthy dose for that.
Okay.
There's certain diseases, particularly ocular melanoma, that presents as miliary disease that has like no options, especially if they don't have the right mutational for the systemic therapy to benefit, but they have like nothing, right? And so you're stuck with, a lot of other therapies, Y90 being one of them. It is a really struggle to know how to treat them. Since they have nothing, I tend to just dose to normal. So, 40 gray MERD if I'm using resin, 70 gray MERD if I'm using glass, just knowing that it's safe. The last thing I want to do is hurt somebody by assuming a T to N and making up tumor volumes and stuff like that.
You can't, right?
Now, if they have like neuroendocrine tumor, there's a lot of effective therapies for neuroendocrine tumors, right? Besides radioembolization. That might be somebody I walk away from. And I say, maybe you're not right for this. Maybe you need PRT, maybe you need CAPTEM, maybe you need, some other therapy. Cabozantinib now works for that. So maybe you need something else.
How do you pick high particle count, low particle count?
We know that the higher particle count you infuse, the more homogeneous your radiation dose is going to be.
Yeah.
And in particular for miliary disease, I'm going to try and optimize as much as I can go into the tumor. So I would use the least particle count that I can. I don't know if that's the right answer though.
You would drop your particle count.
Yeah. I would use the fewest number of spheres that were the hottest.
Okay. All right. Got it. Well, again, to your point, I don't know that we know all of these answers, right? We're still trying to figure all of this out. And that is it's a topic that we haven't quite gotten to, right? And I'll also say the only case of radioembolization induced liver disease in my career was a melanoma patient with biliary disease, and I chose to give a MERD dose. This is several years back. Gave a MERD dose of 110 gray, and it was the wrong answer, right? And we did to the whole liver. So very valid point. You just can't give MERD doses like that in those patients. All right, let's do some more cases.
Let's do it.
All right, Zach, I think this is one of yours.
Oh, this is great. So this is a 65-year-old woman. She has rather indolent stage 4 colorectal cancer. She had a 2 centimeter segment 8 that got SBRT, and it grew to 4.1 centimeters now. CA is 10, LB 1, otherwise quite functional.
The SBRT didn't work.
So this is what we're stuck with. We have this tumor here now. So before we go to the next slide, what are you guys thinking? What do you say? Solitary metastasis here? Thinking of ablation based on the collision trial, not some other therapy?
I think ablation is reasonable, but that is a big ablation cavity that you need to produce to cover a 4 centimeter tumor, right? So when we're at this moment, we use New Wave, rest in peace. So this would be probably to cover this, it would be a 3 probe microwave ablation. If I see a tumor that's bigger than 3 centimeters, my first approach is I'm going to do a mapping. I'm going to do a mapping and see if there's enhancement of the tumor that I might be able to drive an ablated dose in.
I might also consider a PET as well and just see if there is a active edge as opposed to the whole lesion. And then maybe I can target that in one of numerous ways, as we've said.
Okay, so I mapped the patient, phoned a friend, and Tyler.
This is a Y90
podcast. I should map it, and so I did. And you see my nice 3 fiducial markers right there.
Yeah.
And
there's some uptake in that thing.
Yeah. So I think the next slide actually has a cone beam. Yeah, so here you see, here's my cone beam CT here.
Mm-hmm.
It's a little bit over 25%. Again, it's the anterior sector. It's being supplied by both segments 5 and 8. The left is the axial and the right is the coronal. But I clearly get the whole tumor uptake. And what are your doses to this?
Well, it's ablative. So I'm probably, again, not that I'm just going off of HCC stuff, right? I'm going 400 gray to the perfused territory. And that's kind of my floor, right? I wouldn't be shy about going up to 500 or 600. Again, I'm using glass. I think if I were using resin, I might dial it back a little bit in terms of dose to the perfused. I'm still at the mindset of high sphere activity, low particle count, regardless of what product I'm using. So it's kind of I do week 1 if I'm glass. If I were using resin, it would probably be in that 5 to 7 day pre-cal. That would be my approach to this.
Yeah, it's a great question. It's a peripheral lesion. So, we talked a little bit earlier about dropping doses. It's the central lesions, the ones with biliary incompetence. Those are the ones that I tend to not go super hot. But something like this, as long as a perfused volume, the PLT or the perfused volume to normal liver ratio, and that percent was not super, super high, I would go 400, 500 with glass, not even think twice about it. And if I was using resin, I'd, again, 6 day pre-cal. Well, I don't have 6 yet, so 5 day pre-cal for me. But I routinely target 400, 450 with 5 day pre-cal on the resin side. So
yeah, well, to get into my earlier point about these numbers very much changing very quickly.
Yeah.
When this patient was treated, you could only get 3 day. 4 day and 5 day didn't even exist at that point, right? So I treated with 3 day, to your point, targeting 250 gray MERD. And again, for simplicity, I just use MERD for these, because we don't have ablative numbers, right?
Mm-hmm. Yeah.
And in my experience, whatever that's worth, it could just be, anecdotes.
We don't have ablative numbers for glass either.
No, right, exactly.
So,
right. So this is all made up, right? Yeah. 250, 300 MERD seems to be like my sweet spot with resin.
Yeah. Okay.
And so that's what I did here. And here you can see my uptake. And I don't know if I put a follow-up. And here you can see the 6-month follow-up.
If you had higher pre-cal available to you, at this point in time, would you have considered doing, great case with 3 day pre-cal, would you have done a 5 or 6 day pre-cal instead, or would you still do 3 day pre-cal?
I think that's what I'm still trying to figure out in myself. I feel like we kind of live in omnivore's dilemma sort of situation right now where you go to the supermarket and you can eat whatever you want because there's like 45 things of everything. Like, what's the right answer to choose? I really hope in the future we start consolidating things down into maybe 3 choices, right? You have your high particle, low SA, you have a medium, and then you have a high SA, low particle count, right? And so you get to choose, do you want a high, medium, or low in the future? That'd be my dream, right? So we don't have this debate like, if I said I used a 4 day and you said I use only a 5 day,
Right.
Pre-calibrated, like what does that actually mean?
Mm-hmm.
Right? And so difference between individual days is a little nebulous.
But I think we all agree, as you decrease particle count, you need to go up on specific activity per particle.
And vice versa.
And
Yes.
vice versa. Yeah,
They're
absolutely.
inversely related. Yeah.
All right. Next case.
So again, this is a more difficult situation.
Yeah.
Now this is a colorectal cancer patient. You can see they had a right hepatectomy with hypertrophy of the left. Now they have 3 tumors. Based on collision, my gut is saying ablation, but then I see that caudate lesion, and that's tricky.
Mm-hmm.
Even with my robot, I don't know how I would ablate that. So I guess one would think you could ablate those other 2 and then do ablative radioembolization for the third. Would you just selectively target each and ablate them to ablative dosing to each of them? Or are you worried that there's not that much liver left because they've had the right hepatectomy? How do you target that, et cetera?
So I've seen this. I think if I'm going to approach this, if Y90 is in the algorithm, I'm going to do a mapping first before I choose to ablate anything. Because if I know that I'm going to need to Y90 that caudate lesion, I might as well get the information on the mapping side to make sure that there's nothing that would deter me from doing a microwave ablation to the other 2, or maybe there's isolated perfusion to the other 2 and Y90 is easier than microwave ablation. It may not be, but I would at least gather all the information before jumping down a treatment approach. So mapping first, and if it's easy to microwave the 2 on the left, I would just Y90 the caudate. I wouldn't be opposed to Y90ing all of them, even if that's the only liver, because that liver is that's a hypertrophied left lobe. So if you can keep your perfused volumes on the very low end, you're sparing a lot of normal liver. So I think there's multiple ways to do it, but you need the mapping first to make a decision.
In my experience too, to your point, if they're far enough out from surgery, like this was a 1300 cc left lobe, that's a normal sized liver.
Exactly.
Right? Yep. So even though he's had the right hepatectomy, he has a normal sized liver now because it's been long enough.
Mm-hmm.
Yeah, I agree. And I agree with both of what you said. I would not fault anybody for ablating the anterior 2 lesions. I think you could even feasibly place a probe into that caudate lesion from a left anterior approach. The problem is, how do you get a margin, and how do you not take down the left hepatic biliary tree, right? And that's the issue with that posterior lesion. So I would 100% map all 3 lesions, and if you could pick them all off, great. If you can pick off 2 out of the 3, ablate the third, great. I think there's no right answer here, right?
So we did exactly that. So we mapped the patient, and we saw that there were tiny little twigs going to each of these tumors individually. And so we opted to consolidate into one outpatient procedure rather than having multiple outpatient procedures. So we did selective infusions for all 3 of these, ablative dosing.
What'd you use?
Here you go. So 250 gray. This time I had 4-day pre-calibrated.
There you go.
Doses. I don't know if I have the next slide, if I have the outcomes. Yeah, here's 2 years later.
I think it looks awesome.
Yeah.
So some of these tiny twigs of vessels, 3 GBQ vial versus now we have 5-day pre-cal, right? Versus a small perfused volume 5-day pre-cal dose. Do you sway one side? Well, I know you do, but sway one side or the other?
Not particularly.
Okay.
I think, a lot of the fears of reflux, a lot of the reflux was solved with resin microspheres when they got rid of sterile water.
Absolutely.
That was very spasmodic in my experience. We saw reflux all the time. The second thing that was the benefit is we don't have day of calibration anymore. Yeah. You're not trying to put 32 million spheres into the small little territory. In my experience with these high pre-cals, 5, 6, 7, I have not seen reflux, even in these relatively small volumes.
I think that's a reasonable approach. We are glass heavy, so we would probably be doing 3 GBQ vial, which is the smallest vial size you get. But I wouldn't fault anybody for doing 5, 6, 7-day pre-cal. I think you clearly got an incredible outcome 2 years down the road.
And so when you get to your 6, 7-day pre-cal, you're week 2, Tuesday, Wednesday.
You're getting close to the...
Right? And so if you had a 3 GBQ week 2 Tuesday, you would just have no thought about it, right?
Exactly.
And we're getting to parity.
Yes.
Between the specific activities between the products. And in some ways, that's going to make things a lot easier in the sense that the dosimetry will converge along one dose. We won't have, one dose for this and another dose for that. And in other ways, it's going to be harder because you're going to have fewer options. Like if you really want to put 1,000 million spheres into a 14 centimeter tumor, you may not be able to.
Yeah.
Right. As we start to converge on each other. But you may not need to either. Yeah. So we just don't know.
Great points. Let's say this patient had an hepatic OJ. Right hepatectomy.
That is a great question, and I think that definitely needs to be discussed. So, you better antibiotic. They need prophylactic antibiotics. They need on the front end.
Yeah.
And then that needs to be continued.
What do you use? What's your protocol?
So we do Avalox when you can get it, or moxifloxacin. I think it's 400 milligrams BID. I think that's the dosing. If I'm wrong, edit this podcast. It might be daily. It might be.
It's daily.
Yeah, I think it's day, whatever. It's good. Thanks for correcting me. I'm not the pharmacologist here. But we do Avalox, moxifloxacin.
And you started 3 days before.
Yes.
And you go
at least a week after.
Okay. So I actually go 17 days.
Yeah, I was going to say at least a week. Yeah. The problem here is that you are creating necrotic cavities.
This is an ablation.
Yeah, right.
This is a transarterial ablation.
And so there's going to be eventual reflux into a necrotic cavity.
Yeah.
So you can still get infected a year down the road. Yeah. And that's not to say you shouldn't go ablative here, right? We're trying to kill tumor, but you also understand that down the road there may be a component of infection. I don't know when obviously there has to be a cutoff for how long you can give a patient antibiotics, but there's always the chance that these can get infected down the road if they have an incompetent sphincter that allows reflux of, bowel bacteria into the biliary tract. What's your thoughts, Zach?
So let's start with what we know. I know we can get into, again, fantasy land.
So pragmatic.
This is a fantasy land. Yeah, I'm not a pessimist. I'm just a pragmatist. So let's say what we know. So there was a large multi-center retrospective study done in 2018, 2019, published in Radiology. It's biliary complications with incompetent sphincter of Otis, if you want to Google it. And they looked at 100-something patients, and they found that 11 patients ended up getting biliary complications, mostly sepsis, right? In most of those patients, it was with glass microspheres compared to the resin microspheres. I think it's entirely a function of the higher specific activity. Again, not that there's anything intrinsic about glass that made people more likely to get infections. And so I tend for these patients who have incompetent sphincters of Odie or hepatic OJs or whatever to err with resin. And again, I would not use the 7, 8, 9, 10 or whatever they come up with pre-calibrated vials, because I think the safety you're getting is going to be less. And so that's the first, pragmatic one. And, it was relatively low. I think it was like 10 of 120. It was like 11%. Sure. 11% of patients had biliary complications, right? And so you just have to tell the patient, you're at an increased risk of having a biliary complication. It's not 100%, but it's 10%, where it's like less than 0.2%.
It's not negligible, right?
Right, with competent sphincter of Otis. The second thing is, I don't know how many patients in that study got ablative dosing. In my experience, ablative dosing, to your guys' points, I've had a lot of biliary complications to the point where I really, really, really don't like to do ablative Y90 in patients with hepatic OJs. Yeah. I also get very nervous about doing percutaneous ablation in those patients too. I don't do TACE in those patients. You're really going to end up with a lot of biliary complications. So what are you left with? My go-to is either IRE or SBRT, because I think those two, in my experience, those two therapies have had the least number of biliary complications. I have not had many biliary complications like low-bar palliative dosing, and so patients with neuroendocrine, pancreatic neuroendocrine tumors who've had a Whipple, and or patients with pancreatic cancer who have favorable biology with a Whipple, or duodenal cancer, I will do the partition dosimetry, heavily give antibiotics like you guys mentioned, but I really shy away from ablative anything in these patients.
Yeah, I think it goes back to that necrotic cavity, right? At some point it can get seeded, and if it gets seeded, it gets infected. I think I've seen it happen, and it happens in patients with big ablative doses that result in they have necrotic liver. Sometimes there's a compromise, right? Like if it's a big tumor, or Y90 might be the only option if resection's not on the table. And so sometimes you just say, we're at an increased risk of an infection. There's no other alternative. SBRT is probably not even an alternative. Or if you want to take this chance, you recognize we could be headed down this road. But I think there needs to be discussion on the front end with the referring provider and with the patient. This is where we got to go. And if you feel comfortable going down this road with me, then that's what we'll do. You would rather us hold off, well, then that's totally reasonable too. So I think both purchase.
I think all great points. I don't offer thermal ablation at all anymore in these patients, because even on the antibiotic protocol, I feel like 60% of my patients get infected. Don't offer TACE, to your point. Is there a role for sub-ablative dosing in these patients? Is that more analogous to SBRT? We don't have a radiation oncologist here with us today. I don't know if they would radiate all three of these sites. Would you go to 150 gray and see what you get?
For what I go to 150
for this patient?
Yeah, this is metastatic colorectal.
Yeah.
if I'm going in there with ablative intent, at the end of the day, an ablative
take the risk.
you got me on that biliary, right? If I'm going in there saying that 250 is ablative, I'm going in there with the intent to kill it, does it really matter once I've gone above 250? It's just going to be more dead, but it's still dead tissue. So I don't know that I would dial it down if my intent was ablative.
This patient has a competent sphincter vodi.
Yes.
Right.
I see.
Yeah.
Oh, I know, but
if this was somebody like that, yeah.
Then you would dial it down and you would offer
I'd probably offer palliative dosimetry here.
to each lesion.
I've just had so many abscesses.
You haven't had that many, huh? So many?
With ablative dosing, with incompetent sphincters of Odis, yeah.
Well,
I've
it's
seen,
transarterial.
I've had it happen a couple of times, but we've gotten somewhat lucky.
Yes.
And not to say it doesn't happen, it happens.
Or maybe I just have selection bias because it can be quite devastating.
Yes, I agree.
Maybe it was
I remember a guy. I certainly remember a guy that got it, but it's not. I wouldn't feel like I see it a lot.
Yeah, maybe I just remember the numerator much more than the denominator.
Yes, exactly.
Yeah.
We only got a couple minutes left. I appreciate both of your comments and input. I mean, it's been a great session. Any burning thoughts?
I always love getting Zach's opinion on his concepts of dosimetry.
And as we all know, there's not a complete consensus on everything. There are things that we know, there are things that we don't know. There are different ways to approach these lesions, multimodality, not just Y90. There's a lot of options for these patients, right? So we
what makes me
personalize this plan.
the most excited is we were not having this conversation 3 years ago.
Yep.
Exactly.
Right? So I can only imagine what 3 years, they're going to look back at us saying, some of the stuff we said today.
So archaic.
What do you mean they're going to look at us? We're going to look at us.
No, this would be somebody else. So archaic.
Yeah. Well, I'm going to solve the abscopal effects. I'll be on my yacht.
Oh, there you go.
Yeah.
There you go. Well, thank you both. And obviously Nima's not here, so thank you, Nima, as well. But this has been a great couple of hours kind of just discussing this. And I learned a lot. Hopefully you guys did as well. And hopefully those that take a listen do as well. So thank you both.
Great job moderating, Kavi. This was awesome, man.
Thank you.
Thank you guys so much for tuning in. If you haven't already, please be sure to subscribe, follow, and rate the show. Let us know how we're doing and what we can do to improve it. We work really hard at making this a valuable resource for you, and we want to continue to do that. So give us your feedback. Lastly, tell a colleague about the show. We think they'll like it. If you have any questions or comments, direct message us at _BackTable on Instagram, LinkedIn, X, TikTok, and Blue Sky. BackTable is hosted and produced by myself, Chris Beck, and co-hosts
Ali Behetti,
Michael Barraza, Sabine Dond, and Aaron Fritz.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang, Manisha Naganathanahali,
and Manbir Singh Sandow.
Administrative support provided by Judy Dela Cruz.
Thanks again and see you next time.